Yes. So what is emergencies in dermatology? So in a definitions, if you see the definitions, it is nothing but is an acute loss of skin that leads to loss of thermoregulatory metabolic systems as well as infection control, and that leads to the sepsis. So patient can go to the septicemia. Main is you have lost all function of skin. So there is an emergencies. So this is emergency. What if how to approach this type of patients when it comes to OPD or maybe an emergency? In fact, such type of patients often they come in an emergency only. So how you will approach? So first thing to remember is don't be so rush. So immediately you should not rush like anything, like immediately you have to do everything. Not like this, in emergencies. So how to approach this unidentified lesions? First, you should know the things. Though you must know is in this before going to details is how to describe the rashes, like what is papules, what is macules, and what is exfoliation, something like this, and the basic lesions of the days, and is this patient is on toxic or this is a non-toxic rash. So you should differentiate, and minimum management you should know. There is resuscitations, something like this, and how to when and how to talk your consultant. Say being a junior or intern, you may need to consult your senior consultant or maybe senior resident SR and all. So why dermatological emergencies are important? It has been found like about 5% all emergency patients are the dermatological emergencies. So this is also one of the important thing. So first step is when the patient comes to you, first step is you just talk to the patients quietly, calmly, quiet would come and talk to the patients, and then you should know the morphology, what type of morphology he is having, and the things. I think you all know this morphologies: macule, papules, nodules, and bulli, petechiae, purpura, scales. So vesicles bulli are the vesiculous disorder symptoms, and you should also know what is a primary and what is a secondary lesions. So these are some secondary lesions is erosions, like after primary lesions you have erosions, that is a secondary lesions. Ulcer is again another secondary lesions, excoriations, crust, lichenifications, atrophy, and scales. You all should know all these things so that you can easily differentiate the different type of diseases which causing emergencies in dermatology. So step 2 is just naked the patients. So in a broad daylight, proper light, you should naked the patients and basically undress the patients and see the morphology of the lesions. Either it is a papules or it is a macules or it is a bulli. So and see the arrangement, like arrangement. So arrangements give you some clue of your diagnosis. Something like if you see the group vesicles in a dermatomal patterns, so that will give you the idea of this is a herpes zoster. And the distributions, again I said the dermatomal distributions means suggestive of herpes zoster as an example. And extent, say extent of the disease, extent of the lesions will give you the how severe is the disease, and evolutionary changes how the lesions are evaluating. You should take the proper history and see that the patients see in the patients itself. So next questions is you should know which patient is sick or not sick, which is immediately you need vitals immediate care, and which is not needed immediate care. So you should use a red flag, so that you will come to know by the history and vital examinations as well as important lab investigations. So if patient is serious enough, so you should give the red flag. So there are 6 modified links algorithms which can differentiate various diseases and which doesn't come close to your diagnosis. So 6 among 6 is diffuse erythematous, non-erythematous, maculopapular, purpuric, vesicobullous, and postular. So these are the 6 morphologies, and how we'll come close this linked algorithm is, see, possible life-threatening rash when you see this thing. So if it found it is a solid means if it is a non-erythematous and nothing to do, and if it is erythematous or if it is maculopapular or purpura or diffuse erythematous, or if it is a fluid field, either clear or pustular. See, if it is a clear, then it's a vesicobullous. Among the solid, if it is maculopapular, if it is a central part, then you should think of viral exanthem, Kawasaki disease, and drug reactions with eosinophilia with systemic symptoms. So if it is not sick, that means that could be the drug reactions, pityriasis, tinea, or maybe the viral infections again. If it is in a periphery means this probably is erythema multiforme, Stevens-Johnson syndrome, Lyme's disease, meningococcemia, syphilis, early toxic shock syndrome, and Rocky Mountain spot fevers. Although we don't see much of Rocky Mountain spot fever. And not sick means either maybe scabies, or atopic dermatitis, psoriasis, or tinea. So these are the if you found maculopapular rash. So these are the you should keep in your mind and the differential diagnosis. So next is when there is petechian purpura among the solid. So if it is a palpable, then again you should think of meningococcemia and disseminated gonococcemia, endocarditis, Rocky Mountain spot fever, and henoxyolin purpura. If it is not sick, could be the autoimmune vasculitis or henoxyolin purpura. Non-palpable purpura or petechial means either DIC, disseminated intravascular clotting, or TTP, thrombotic thrombocytopenic purpura. If it is not sick, then it could be the ITP, idiopathic thrombocytopenic purpura. So again, if it is a diffuse erythematous among the solid, means if it is a sick, then see for the Nikolsky sign. If it is a positive, then it could be the staphylococcal skull dead skin syndrome or toxic epidermal necrolysis or DRESS. If it is negative, then TSS, Kawasaki's scarlet fever, erythroderma, Reitman syndrome, early necrotizing fasciitis. Not sick, it could be anaphylaxis, scromboided alcohol flush. This could be the possibility. Some if it is a fluid filled vesicles, if it is a clear then it is a vesicobullous disease. So in that case, if it is a diffuse one, then varicella, chicken pox, disseminated gonococcemia, DIC, TN, pemphigus vulgaris can be think of. It is again not sick, either it could be pemphigus vulgaris or bullous pemphigoid. In case of peripheral, again it is a sorry, it is a necrotizing fasciitis, pemphigus vulgaris, and foot mouth disease. If patient is not sick, could be the contact dermatitis, zoster, vesicular eczema, or maybe the post burn. So some of the things you should not miss, and you should not miss in the emergencies. These are the fixed drug reactions, disseminated viral infections, that is varicella zoster or herpes zoster, herpes simplex virus, erythema multiforme, Stevens-Johnson and TN, anaphylaxis, angioedema, bullous pemphigoid, pemphigus vulgaris, Rocky Mountain spot fever, TTP, DIC, meningococcemia, disseminated gonococcal infections, toxin-mediated, that is Staphylococcus scalded skin syndrome and toxic shock syndrome. Among the exfoliative, erythema, you should see the erythema, eczema, and psoriasis. DRESS syndromes, you should not miss out. Necrotizing soft tissue infections. So you should not miss out all this. So because they may lead to the fatal. So start with the DRESS syndrome. So its clear picture is look like a dress. So you can see there are multiple erythematous skin among the in between there are multiple white spot. Although in Indian skin we hardly see because we have a type 4, type 5 and type 5 skin, so we are dark skin, so we don't see this white spot. Um, so what this DRESS means is a drug reactions with eosinophilia and systemic symptoms syndrome. So nothing but it is a severe adverse drug reactions with fever, rash, and internal organ involvement. That is the most commonly involved is the liver. And the common cause is mostly anti-epileptic motor stabilizer. There is phenobarbital, carbamazepine, phenytoin, lamictal, sulfur drugs, dapsone, modafinil, and human herpes virus 6 infections can lead to the DRESS syndrome. What is pathophysiology of this? Although exact is not known, but it has been suspected T-cell mediated reactions. It has been suspected, and a potential genetic predispositions has been noted in this. And around 10% mortality are there in DRESS syndrome. So diagnostic criteria depend on Regiscar and Japanese consensus groups. Management is only supportive. If you need immediately admissions, associated organ dysfunctions to be taken care. So what is a Regiscar? Regiscar is something like among these 7, you should have these all 7 or 6, or either maybe first 5 among the criteria when it is called atypical one. So typical drug induced hypersensitivity, this thing DRESS or thing is when you see the maculopapular developing more than 3 weeks after starting the therapy, or persistent clinical finding after drug withdrawal, fever more than 38 degrees centigrade temperature, and hepatic abnormalities, leukocyte abnormalities. There is leukocytosis. There are more than 11,000 per millimeter per cubic millimeter, and atypical lymphocytes more than 5%. Eosinophilia more than 1500, and human herpes virus reactivations. So these are the things you have to remember when to qualify DRESS syndrome. So next comes as a Stevens-Johnson syndrome and TEN or toxic epidermal necrolysis. So it is also known as Loyal syndrome. It is a rare, acute, and life-threatening mucocutaneous disease that occur as consequences of extensive keratinocyte cell death. So that's why you see the peeling of skin. Differentiations among Stevens-Johnson and TEN, that is toxic epidermal necrolysis, is when we qualify Stevens-Johnson is when skin detachment is less than 10% of body surface area, that is Stevens-Johnson syndrome. When it is more than 30%, then it is qualified 10, that is toxic epidermal necrolysis. In between, that is 10 to 30% of body surface area is known as overlap of SGS 10. So these are the differentiating point. If it is less than 10% as SGS, and if it is more than 30% as S is 10. So here is some pictorial presentations. So first one is a less than 10% Stevens-Johnson, and last one is more than 30% of skin detachment. So etiology, again, it's a most commonly is a drug. So there are a list of drug. You can see allopurinol, aminopenicillin, sorry, imetazones, antiretroviral therapy, barbiturates, carbamazepines, chlormagenon, phenytoins, lamotrigine, phenylbutazone, peroxycam, sulfadiazines, sulfodioxins, sulfasalazine, and trimethoprim sulfoxide. There is Septron. And infections can cause this type of infection, and sometimes after immunizations also can have. So this is how clinically see. You can see here skin detachment, so you can easily peel off this. So this is Nikolsky. This is known as pseudo Nikolsky signs positive. Here is a severe one. See, it has a more than 30% body surface area involvement, so it is a 10. So you can see here it's peeling of skin. So here is involvement with the drying up, so you can see hemorrhagic crust. So you have intensive care in these patients, like burn patients. You need to do this is mucosal involvement of SCS. So you can have even similar lesions over the oral mucosa itself, as well as female genital mucosa. So diagnosis is most of the time is a clinical diagnosis. Nothing need no special investigations is required for a diagnosis with a history of typical drug intake, and the investigations are required for treatment purpose only, like serum electrolyte is the most common involvement. CBC, again urine examinations for to test to give certain drugs, blood sugar, liver function test, renal function test, exposures, HIV, including. Biopsy is often not required, but if you go for biopsy, then you see the supravascular layer apoptic keratinocytes. Lateral in the lateral lesions, you can have full thickness epidermal necrosis and separations. Differential diagnosis. Sorry. So differential diagnosis, what are the differential diagnoses is, one is erythema multiforme, major staphylococcal scalded skin syndrome, acute generalized exanthematous pustulosis, generalized bullous fixed attack eruptions, burn, grub versus host disease, pemphigus are the common differential diagnosis. So score 10 is a system where how to score the severity of the disease. So although it is not usually calculated by the interns and all, but it is mainly for dermatologists. But you should also know if it is a point wise. So you can see if it is more than 40 or more than 40 years of age is 1. Heart rate, if it is more than 120, then it's again 1. So everything is given 1 1. Body surface area involved on 1 day. Day 1 above 10% is 1. Again serum urea level more than 10 is again 1. Serum bicarbonate level 1, more than 20, less than 20 is a 1. And serum glucose level, if it is 40 millimole as per liter is 1 again. So severity depends on, so 0 to 1 is 3% mortality. If it is more than 5, means mortality is 90%. So you can see. So how we'll manage this correction of fluid and electrolyte imbalance. Nutritional support, temperature control is most important. Wound care is the biological dressings, condensed compresses, petrolatum, impregnated gauze can be used, so that when you remove it, it should not stick off with the skin. Ophthalmic care is again important, because it might lead to blindness because of this thing, synesthesia. Antibiotic, if it is needed, you should give antibiotic. Complications is again fluid and electrolyte imbalance, infections, scarring and depigmentations as infections. Once you have the adhesions, that might lead to the blindness, as I already mentioned earlier also. Acute renal failure, so this is the thing. So mortality is as general as if it is a Steven Johnson, it is less than 5%. In case of 10, it's around 30% is mortality. Erythema multiforme is another emergencies in dermatology. It is nothing but an acute self-limited skin disease characterized by abrupt onset of symmetrical fixed red papules, some of which evolve into typical oblique atypical papular target lesions. So it is an acute self-limited skin disease which has an abrupt onset symmetrical fixed red papules with typical and atypical target lesions. So this is the things to remember. Epidemiology is more commonly same as TN, Johnson syndrome, and commonly seen in a male. Epipathogenesis is SSB is most commonly associated with infectious agent. So these are the epipathogenesis. You can see a list of the viral infections. SSB S1 and 2, parapox virus, vaccinia, varicella zoster. So there is a list of virus. This everything is and a drugs, primary non-steroidal anti-inflammatory drugs, sulfonamides, anticonvulsants, other things. Some exposure unusual poison IBEs can also give. Systemic diseases, inflammatory bowel disease sometimes can give erythema multiforme. Lupus erythematosus. It is Royal syndrome and Behcet disease can also give rise to this erythema multiforme. Clinical features as skin lesions and a typical target or iris lesion can be seen. It is less than 3 centimeter, regular, round, and well-defined borders, lesions, and it has a 3 distinct zones, that is center dusky zones surrounded by paler zone and peripheral edematous halo. So this gives you the clear target pictures, targeted lesions. And sometimes when you have atypical, these 3 layers may not have, only 2 zones are the defined visibles. So these are the atypical target lesions. So similar region can be seen in the Stephen Johnson. So here what I was talking. So here you can see the clear 3 layers of target lesions. So this is another one, target lesions. Among that you may have cobnerations in case of the multiforme. So sites commonly is seen in extremities and face, and they usually appear in groups. Kubner phenomena is seen as shown in pictures. Macro lesions are the limited and sometimes absent, and erythema multiforme minor, present in erythema multiforme measures. Vesicular lesions are, and they are becoming painful in case of measures. And these are the commonly seen in buccal mucosa, lip, oral, and orogenital mucosa. Systemic symptoms are the limited, and it may absence in case of minor. So they are the fever, arthralgia, pulmonary involvement. So natural history of the disease, they usually appear within 24 hours and last for within 3 days. They fully develop the things and practice and will without any sequences. So it's a good news, good thing. So they do not leave any scars or any sort of abnormalities in your skin. So differential diagnosis, sometimes you may confuse with urticaria, FDE, that is Victor correction, subacute lupus erythematosus, erythema annulare centrifugum, vasculitis, etc. So treatment is a precipitating factor. Erythema multiforme minor is a symptomatic treatment is sufficient. There is antiseptic, antihistamines, rinse, and local anesthetic lesions for oral lesions, and again ophthalmic preparations for some so ophthalmic preparations. So in case there is a viral infections, we need to give cyclovir or valacyclovir or famous cyclovir depending on the dose, age of the child, dose of the different. There's 10 mg per kg in case of acyclovir. In case of severe form of erythema multiforme, so with functional impairment, sometimes you may need to give systemic corticosteroids, that is 0.5 to 1 mg per kg can be given. So next emergency is acute urticaria. Sometimes these patients comes to your emergency. Acute urticaria is nothing but it's a recurrent, transient, cutaneous swelling and erythema. So it's a wheal. So typical lesions is in and as an arterial wheal, can be an acute and chronic. Less than 6 week durations of arterial lesions as a acute, and if it is lasted more than 6 weeks, that is on and off coming, then it is a chronic urticaria. Pathophysiology, it's a result from the release of histamine, bradykinin, leukotrienes, C4, prostaglandin D2, and other vasoactive substance from mast cell and basophils in the dermis. And this substance causes extravasation of fluid into the dermis, leading to the arterial lesions. So here is the pictures. You can see these are the wheals, erythematous rash. So here is a dermographisms. You can see. So among this, again, another common is angioedema. This is again emergency. So sometimes if it did not taken care properly, so patient may lose the life also because of difficulty and breathing when they involved in the oral this thing, respiratory tract. So it is nothing but there is a localized, sudden, transient and often recurrent swelling of the skin, subcutaneous tissue, submucosa, and usually resolve within 72 hours, occur for less than 6 weeks, and differ as an acute angioedema. It is again it may be associated with arterial 50% of cases. It results from the interstitial edema from the mediator affecting the capillary and venule permeability. So here is the pictures. You can see this is a normal, and when the patients have acute angioedema, see, so this maybe sometimes blocks your airways, so this may lead to difficulty. Another one, you can see angioedema here, both the eyes has been closed, see upper lip has been involved here. Complication is life-threatening because of airway blockage. Anaphylaxis can occur, so you need immediate attention to these patients. How to approach this type of patients is comprehensive detailed history must be taken. So there is drugs, food, physical trigger, infection, etc., etc. And laboratory investigations is again those are complete blood count, ESR, LFT, and antithyroglobulin, antimicrosomal antibodies, urine analysis, stool for ovarian cyst. Skin testing may be done. Skin biopsy is not necessary but can go for immunofluorescence. Treatment is depend on the severity. In many cases, swelling is self-limiting and resolve spontaneously after few hours or days. So this is the algorithm how we'll treat. So monitoring of the vital functions, rating of angioedema status, supply of the oxygen, emergencies, pharmacotherapy, that is something we may need intubation and tracheostomy. So these are the things you need to do. Physical examinations needed for laryngoscopy. So common drugs, which is diphenylhydramine, cetirizine, loratadine, fexofenadine are the first line of the therapy to be used in case of urticaria and angina. Both ranitidine and cimetidine can be added. Triglyceride antidepressant, if it doesn't respond, then can be added. Both S1 and S2 activity. Sedation is limit of these are the among this use. There is doxep use. Epinephrine, sometimes you require in case of when there is a respiratory tract involvement. or whenever patient is in shock. So this is a showing pictures, tracheostomy and laryngeal intubations. So how will prevent? Avoid irritating the affected areas. Hello. हेलो हाँ मैं क्लास कर रहा हूँ हेलो stay away from the allergens. Never take medicines that are not prescribed. Erythema is another again emergencies. When we will call erythema is when there is erythema and swelling involving more than 90% of body surface area involved. Primarily, erythema is often initially on tongue. So primarily, erythema is often initially on tongue, then extended within a few days and a week to week to enable the whole skin surface, following by the scaling. In case of secondary, it is a generalizations of a preceding localized skin diseases, maybe either psoriasis, eczema, or atopic eczema. So these are the things causes of erythema. First is when you have a erythema can causes by the other pre-existing diseases like eczema, psoriasis, pemphigus foliaceus, pityriasis rubra pilaris, ichthyosiform erythroderma. Miscellaneous can causes is sarcoidosis, hairy disease, dermatomyositis, lupus erythematosus, graft-versus-host disease. Drug can causes there are heavy metals, arsenic, barbiturates, captopril, chloroquine, dapsone, gold, penicillin, rifampicin, isotretinoin, sulfadiazines, tetracycline, thalidomide. Infections. Infections, generalized dermatophytosis, HIV infections, Norwegian scabies, malignancies, cutaneous T-cell lymphoma, Hodgkin's disease, other lymphomas and leukemias are the causes of erythema. Pathogenesis is still not clear, so it has been believed that the condition is secondary to uninstigated interactions of cytokines and cellular adhesion molecule, and this interaction result in increase in epidermal turnover rate, increase number of germinative cells and their absolute mitotic rate, shorten of transmit time of the cells through the epidermis that lead to increase in loss of epidermal material together with significant loss of protein and folates. So that's why it's an emergency. The clinical features is primarily it is eczema or associated with the lymphoma is often sudden onset. Scalings are most often is a fine and large, or sometimes it may be lamellar. Color is white brown. Skin become bright red and hot and dry. Hair loss is may be seen due to scalp improvement and loss of body hair. Nail changes, you can see the dystrophic ridge and thickening, or the ridges or thicken, or maybe the shade off. Palms and soles, they may be seen as a featured palms and soles. You may have variable lymph node enlargements, that is dermatopathic lymphadenopathy. Exudations may be seen peripheral periorbital skin is inflamed and edematous, resulting in ectropion. and with consequences epiphora also be same. So here is the picture erythroderma. So one first picture is showing Sézary because of Sézary syndrome. This is of Sézary syndrome, and second one is showing the drug rash. So these are the erythematous rash due to Psoriasis pylorus, and this right one is a pemphigus foliaceus. So again, this is of psoriasis. So here you can see the dry scales. So this is because child with atopic dermatitis. So you have seen the erythema. So why there is systemic disturbance? Because there is increased blood flow in the skin, so that leads to hypothermia, high output cardiac failure, and that leads to a compensated by hypermetabolism, increased metabolic rate. So you need to give. So loss of exfoliations scale is up to 9 gram per day, sorry, per meter square body surface. That leads to hypoalbuminemia, and then lead to the edema, generalized edema, altered immune response because of increased gamma globulin. So this is the systemic disturbance. Diagnosis is again most of the time it's clinically. History is enough. Clinical examinations again is important. Histopathology. 50% of cases you may find the primary disease what causing the erythroderma. Efficacy of lymphadenopathy may give you the clue of if it is malignancy or not. Order the necessary investigations depending on the suspected disease. So management depending on the disease. So maybe topical corticosteroid, sedative antihistamines. In case of psoriasis, you may need to give methotrexate or maybe acetratine. So these are the things depending on your disease. You have to give certain therapies. Complications. Secondary infection is one common complications. Dehydrations is second kind of complication because of excessive electrolyte loss. Sorry, fluid loss. Electrolyte imbalance, temperature dysregulations, high output cardiac failure because of this. Post-inflammatory hypo or hyperpigmentation can be seen once the patients recover. Another emergencies and dermatology is generalized pustular psoriasis. So psoriasis we commonly seen, but these are the rare form of complication of psoriasis. So where you see everywhere is pustules and pustules in case of psoriasis patients. So how will diagnosis is a febrile, systemic ill appearing leukocytosis, triggering factors are the drug, infections, stress, and steroid. Important is because 8 to 20% mortality has been noted in this recorded. Worse has been because, and it can be worse when you cannot diagnose early. So complications, commonly is complications, metabolic complications. So managements, withdrawal of provocative factors, admit a patients, bed rest, fluid electrolyte replacement, analgesia, antihistamines, often need to do ICU, wound care, blunt emollient, wet dressings, mild to moderate topical corticosteroids can be given, and systemic steroids in case of very severe or pregnant with pustular psoriasis. So these are the clinical pictures of pustular psoriasis. Here is a closer view, so you can see the multiple pustules. Pemphigus is again another disease which can come to your emergency. These are an autoimmune bullous disorder which causes intraepithelial blisters. There is separations among the skin. Commonly seen in middle-aged group, there is 3 to 89-year-old can be there, but range can be 3 to 9-year-old. Winter exacerbation may seen. Pathogenesis is it is an autoantibodies against the keratinocyte. Patients develop autoantibodies against the keratinocyte desmosome of the cell's membrane, which result in loss of cell-to-cell adhesions, leading to the intraepidermal cleft. Clinical feature. So, depending on the type, so you have 4 variants of the pemphigus. So, main commonly seen one is a pemphigus vulgaris, then basitans, where you can have basitating growth, then is foliaceous and erythematosus. So, as the most superficial one is the erythematosus. So, commonly encountered variety is vulgaris. So, it is a localized or generalized vesicular and bulla apparently in the normal skin or sometimes in erythematous skin. Initially, these lesions are the tense and clear bulla. Within 2-3 days, that they become fluid filled. Then this become fluid, become turbid. In this case, the Nikolsky signs become positive when bulla spread signs become positive. They rupture easily and leave behind a painful oozing area and then into the skin, and they may be painful. And if they heal, they may leave the hyperpigmentations or hyperpigmentations, but they have a little tendency to heal unless until you give the treatment. Lesions often become crusted along with the painful erosions, heal with hypo and hyperpigmentations as I already mentioned. So this is the clinical pictures of skin erosions, although I didn't see here any bully, but overall oral involvement is common in case of vulgaris. Buccal, palatal mucosa, and gingival mucosa are the commonly affected. There are few uh, uh, may be painful, superficial, and persistent irregular shape of erosions can be seen, uh, and they are covered with a necrotic slab having little and no inflammations can be seen in a moral mucosa. They may sometimes enforce with the candidal infection, so you might need to take care of the candidal infections also. Other mucosas can be involved like genital mucosa. So here is the one picture, so you can see palatal mucosa is involved. Diagnosis, to confirm the diagnosis is Jank smear. As you can see the acantholytic cell in this when you're doing RPD. Histopathology is you will see intraepidermal blisters and raw of tombstone appearance among the keratinocytes. In case of direct immunofluorescence, you will see the immunoglobulin G and C3 deposits in a fishnet pattern. There is a presence of circulating IgG antibodies and blood in case of indirect immunofluorescence. So how the acantholytic cells look like is here. So they are the Roman and well detached from the disease. How the histopathology look like is, see here what I was talking raw of tombstone appearance. This one is intraepidermal cleft. So this is what immunofluorescence show, fishnet pattern of IgG and C3 deposit. Differential diagnosis is bullous pemphigus, dermatitis herpetiformis, erythroderma, epidermolysis bullosa acquisita, bullous impetigo is a differential diagnosis. Treatment: assess the general conditions and extent of the severity of disease, maintenance of fluid electrolyte balance, proper nutrition, control of secondary infections, proper and regular dressings are required. Corticosteroids, there is 60 to 80 milligram per day. There is 1 to 2 milligram per kg per day can be given. That may be increased. Once the lesions are healed up, you can start tapering, and along with you should get the adjuvant sparing agent, that is azathioprine or cyclophosphamide or maybe mycophenol mofetil. So DCP pulse has been innovated and the ordination by Dr. Pasricha that can also be continued for the whole course of the disease. Other drugs has been used. Rituximab presently has been used commonly. IV immunoglobulin, plasmapheresis, absorption of pathognomonic antibodies. These are things Lepra reactions, again another one, because India will never, till now will never unable to free from the leprosy. We are not unable to eradicate the leprosy. So lepra reactions can easily disturb your sleep at night also in emergency. So there are two types of lepra reactions we can see. We have as type 1 and type 2. Type 1 reaction is a type 4 hypersensitive reaction, manifests as aggravations of an existing lesions which become more erythematous and indurated with increased loss of sensations. The lesions may be painful and parasitic. The nerve may become extremely painful and tenderness. So these are the things, because pre-existing lesions become more prominent and erythematous. So this is the type 1 reactions. And in case of type 2 reactions, then there are this is also known as ENL, that is erythema nodosum leprosum. It is an immediate humoral hypersensitivity mediated by the humoral hypersensitivity. It's usually occur later during the course of the treatment for the lepromatous leprosy or borderline lepromatous leprosy. Manifests as a sudden eruptions or tender erythematous consequence nodule appearing suddenly on any part of the body, which may ulcerate. Other cases like joint pain, fever, malaise, tender enlarged nerve, lymphadenitis, epididymolysis, radiculitis, edema of the extremities can be seen or may be present with the ENL. So here is, you can see erythematous lesions. They usually come in a crop, and they are evanescent lesions. Management is continue MBMDT. In case of mild reactions, in case of type 1, you just give the daily aspirin and paracetamols and reassurance of the patient. Severe reactions, you may need to oral corticosteroids. In case of type 2 reactions and mild, again, there is no involvement in other organs and skin, then you can treat symptomatic. In case of moderate disease, so severe ones is you need to immediately treatment. These are the severe ones is high fever, postural lesions, and ulcerative lesions when you see. So in these cases, you in moderate cases you can give chloroquine, anti-inflammatory drugs, and sometimes colchicine can also be helped. In case of severe, prednisolone, clofazimine, and thalidomide is the main drug. Staphylococcal scalded syndrome. There is a potentially life-threatening blistering skin disease caused by the exfoliative toxins. It is also known as Regiscar disease and pemphigus neonatorum. Primarily a disease of infancy and early childhood. Male-female ratio is 2:1, and this is sporadic cases. In case of epidemic, it's a 4:1. So etiology is, as already talked, there is toxin. So these toxins bind to desmoglein 1 directly, causes the conformational changes in the toxin, which cleaves the extracellular domain of desmoglein 1. They act the granular layer of the epidermis to cause a split and sterile bulla. So clinical features, the onset is either acute with fever, rashes, or preceded by the prodrome or malaise, irritability, and cutaneous tenderness, often accompanied by prolonged rhinorrhea and conjunctivitis and otitis media. The typical rash presents are the faint orange red macular exanthem, localized initially on the head and spread within a few hours and remainder of the body. The peculiar periorificial and flexural accentuations is seen. That on the skin develop wrinkles and appear owing to the formations of flaccid bulli within a epidermis. So this is the pictures. Nicholson scientists again positive here. 1 to 2 days bullets out, slough off, and leave behind the moist skin areas of varnish like crust. Patient may show sediment facies, perioral crusting, and radial fissurings with the mild facial edema. Scaling and desquamation continue for next 3 to 5 days, with reepitheliations occur in 10 to 14 days. Lesions heal without any scarring. This is a good thing. So diagnosis is mainly clinical and should take into considerations like childhood develop this generalized tender erythema, most prominently on periorificials. Nikolsky sign is positive. In case of suspected SSS, is supported by the confirmation of staphylococcal infection syndrome in a different site. Investigation, again blood culture most of the time is negative. Culture from conjunctive nasopharyngeal and pyogenic foci are positive. Leukocyte counts may elevate or may be normal. Slight lattice aggregation test, double in diffusions, ELISA are used to confirm your diagnosis. Histopathology, although we never go for histopathology, but you can see as a sharply demarcated zone cleavage at the below level of stratum corneum. No inflammatory cells, and epidermis is a lack of inflammatory infiltrate. So management need to be require hospitalizations beside the proper appropriate systemic antibiotics therapy. The mainstay of the treatment is to eradicate infections, that is staphylococcal infections, which is most common causes of require is intravenous anti-staphylococcal antibiotic, that is methicillin and or flucloxacillin. Subsequently, parenteral therapy may be replaced with the oral. Second line of therapy, so these are the IV macrolides, vancomycins, and IV can be replaced with oral again. Oral fluid intake, careful monitoring of the urine, moist denuded areas of the skin areas should be lubricated within a blend emollient. Thank you. In case any questions, you can text me. If no questions, then I can leave so that you can have another class. Still 5 minutes are left. If anybody has any questions, you can text me. Okay, then thank you.